this. They just watch it online. So thanks for coming, everybody. I appreciate it. It's nice to see everyone. And so today we're going to basically give a talk called Optimizing Your Ability to Fight Cancer. So this is part of the If You Were My Family Member series. And really it's predicated on the notion that I'm probably one of the only people in the world who knew that he wanted to be a cancer doctor when he was 4 years old. So my dad, he was a cancer researcher, and he used to take me to his lab at the Veterans Administration in Minneapolis when I was young. And so the first time I ever saw a cancer cell, the first time I knew I wanted to be a cancer doctor, I was 4 years old. So for the last 42 years, I'm 46 now, I've thought about cancer almost every single day. And that's not an exaggeration. I've thought about cancer almost every day since I was 4 years old. And I always tell people, you can think about cancer every single day, and you can see it Monday through Friday, 8 to 10 hours a day. You can see it on weekends. It doesn't matter, because until you actually have cancer, you have no idea what it's like to have cancer. So when I was making this series, I really thought about what I would want people to know if they were my mom, dad, brother, sister, child. And that's the fundamental metric for me, right? That's how I look at patients. If they're not getting the care I would expect for my mom, dad, brother, sister, child, then something is wrong and I have to fix it. So when I was making this particular series, I thought about, okay, what would I want patients to know if I was in the room with them and they were my family member? And that's how this particular series was born, and this particular talk in particular. So when I was thinking about this talk, right, this seminal talk for this particular series that's supposed to apply to all patients with cancer, what I realized is that this talk is almost impossible to make. Because how do you make a talk that's universally applicable when the population you're talking to is incredibly heterogeneous? You know, no two cancer patients are the same, period. When you've met one patient with cancer, you've met one patient with cancer. So when I came up with this talk, I thought, okay, probably the best way to do it is to give people 10 survival tips, ways to optimize their ability to fight cancer that are relatively universally applicable. Survival tip number 1, the inches matter.
I don't know what to say, really. 3 minutes to the biggest battle of our professional lives. All comes down to today. And either we heal as a team, or we're going to crumble. Inch by inch, play by play, till we're finished. We're in hell right now, gentlemen. Believe me. And we can stay here, get the shit kicked out of us, or we can fight our way back into the light. We can climb out of hell. 1 inch at a time. Now, I can't do it for you. I'm too old. I look around, I see these young faces, and I think, I mean, I made every wrong choice a middle-aged man can make. I pissed away all my money, believe it or not. I chased off anyone who's ever loved me. And lately, I can't even stand the face I see in the mirror. You know, when you get old in life, things get taken from you. I mean, that's part of life. But you only learn that when you start losing stuff. You find out life's this game of inches. So is football. Because in either game, life or football, the margin for error is so small. I mean, 1/2 a step too late or too early, and you don't quite make it. 1/2 second too slow, too fast, you don't quite catch it. The inches we need are everywhere around us. They're in every break of the game, every minute, every second. On this team, we fight for that inch. On this team, we tear ourselves and everyone else around us to pieces for that inch. We claw with our fingernails for that inch. Because we know when we add up all those inches, That's gonna make the fucking difference between winning and losing. Between living and dying. I'll tell you this, in any fight, it's the guy who's willing to die who's gonna win that inch. And I know if I'm gonna have any life anymore, it's because I'm still willing to fight and die for that inch.
So in cancer care, the inches are literally everywhere. If you have a patient who has a fever, in the context of getting chemotherapy where their immune system is sufficiently suppressed, we know that if you delay treatment, antibiotics for even an hour, mortality goes straight up, patients die. If I correct someone's sodium when it's sufficiently low too fast, I can make them quadriplegic. If I correct their high blood pressure too quickly, I can cause a stroke. So in medicine and cancer care, the inches are everywhere. And it's a patient's responsibility to understand what those inches are. They entail quite a bit and a lot of different symptoms, but fevers, headaches that are new onset or wake you up from sleep, neurologic deficits where you can't move an extremity, where you have issues with your vision that's new, back pain that's new, shortness of breath that's new, profound diarrhea. These are all inches. And you need to let us know about every single inch, because if you don't tell us about the symptom and we lose that inch, that can certainly constitute the difference between living and dying. So survival tip number one is that the inches matter and you have to be hyper vigilant, not just vigilant, you have to be hyper vigilant. And I always tell my patients, you can never call me too much, but you can call me too little. When you talk about cancer, what you're talking about is something that's inherently heterogeneous. There are very few universalities in the world of cancer, but there is one I can think about and one that I actually think is probably true. The sooner the better. The sooner we catch your cancer, the more likely you're going to do well. The sooner I know about a symptom, the better you're going to do. So survival tip number one is the inches matter. Survival tip number two, know your opponent. I wrote this article for bioinformatrend.com where I have an editorial series. It's called Quarterbacking a Patient's Cancer Care. And in that article, I equate being an oncologist to being the quarterback of a football team where the owner is the patient, where you're trying to win on your patient's behalf. And what I do as a quarterback is I walk up to the line of scrimmage where I have my teammates, nurses, pharmacists, all of the different pharmaceutical individuals that are involved in helping bring drugs to market, the custodial staff, the clerical staff, everyone on my team. And the first thing I do when I get to the line of scrimmage is I look at the defense and I survey the opponent. I study the patient's cancer because everything I'm about to do has to do with my assessment of that cancer. And as a patient, as a physician, we both need to know the opponent. And what's fundamentally important is that the opponent's never the same. Your opponent is always different than some other patient's opponent. No two cancers are the same. They have different protein expression profiles, different histology. They have different molecular profiles, different stages and amounts of cancer, different locations of disease, and different patterns of growth and response. The biology of the cancer is different. Whenever I see a patient with cancer, it's to me basically like being in a vacuum. No other patient's on my mind. No other patient is the same. If you look at these two patients, they're both patients of mine. Consider this patient on the left. They have a triple negative stage 4 breast cancer. You can see a couple spots here in the liver and a lymph node here in the mediastinum. Consider this patient on the right. They have disease up and down the spine, up and down the skeleton. You can see it in numerous ribs. You can see it in the left femur. You can see it in the right femur. Now, if you looked at these pictures, you would think objectively, this patient over here has a much worse prognosis and is in a much worse situation, but that's not true because the protein expression profile tells the story here. This patient on the left has a triple negative breast cancer, meaning they do not make any of the 3 proteins that we look for, the estrogen receptor, progesterone receptor, and HER2. So they have a triple negative breast cancer, which are infamously difficult to treat. This patient on the right makes the estrogen receptor and the progesterone receptor, but they do not make HER2. They are hormone receptor positive and HER2 negative. Because of that fact, because of that very simple fact, the patient on the right is likely to have a very decent outcome, whereas the patient on the left is going to be a struggle. It's going to be a fight. It's not going to be easy. Not only does protein expression profile tell a story, but the histology of your cancer tells a story as well. So histology is the study of microscopic structure of tissues. And what's critically important about histology is it basically tells me as a physician what I'm treating, right? So pathologists who basically look at the histology of a cancer and tell you exactly what that is, what story that's telling, are incredibly important. We are entirely reliant on our pathologists. And the idea is that the histology will tell you the cancer subtype. It will tell you the cancer grade. So let's talk about subtype for a second. When we talk about lung cancer, right? Cancer is just a cell that grows in an uncontrolled way, breast cancer, breast cell, lung cancer, lung cell. When I talk to patients about lung cancer, I write on a whiteboard for every single patient I meet. I literally give them a talk on their cancer. When I'm talking about lung cancer, the very first thing I tell them is lung cancer is a lung cell that grows in an uncontrolled way. But there's two big types of lung cancer. There's small cell lung cancer and non-small cell lung cancer. And in the non-small cell group, there's different subtypes. There's adenocarcinoma, squamous cell carcinoma, large cell carcinoma, sarcomatoid, et cetera, et cetera. And the subtype matters. The type of cancer matters. The type of lung cancer matters. We treat it differently. It has a different prognosis. We anticipate different things based on the subtype, which the histology tells you. In addition, we also look at grade. So grade gets a little complicated, but the way to think about grade is basically how aggressive does a cancer look when you're looking at it under a microscope? Does it look really aggressive? Are there features that are problematic, or does it look fairly timid? Now, typically we grade cancers 1 through 3 or 1 through 4. The higher number means it looks most aggressive. I want you to ask your physician what the subtype of your cancer is and what the grade is. It impacts treatment. It can impact prognosis. So absolutely, absolutely, I want you to understand the histology of your cancer. Next, something that is actually really important, something I talked about in 2015 when I gave this talk, but I'm going to emphasize tremendously to that, is you have to understand your cancer's molecular profile. So when we talk about molecular profile, basically what we're referring to is the genetic and protein composition of your cancer. Now, the reason it's important is because it can help guide your treatment, and it is particularly important for cancers that are theoretically incurable. In fact, if you have a theoretically incurable cancer, so stage 4 breast, stage 4 lung, a lot of stage 4 colorectal, stage 4 liver, the first thing I want you to ask your physician when they say you have a stage 4 cancer that's incurable is, what is my molecular profile, or are you sending it? You need to know what the molecular profile is. Now, I don't want to get into the weeds here. I actually gave a separate talk that you can see on the Revolution Cancer channel a couple of weeks ago on this particular subject. I'm actually going to do this again for patients in the future to make it a little bit easier. But all I want you to do is look at what I have in green here, write it down and take it to your doctor. I want you to ask them about something called next generation sequencing, NGS. Basically what this refers to is the fact that we are taking your cancer cells, or the DNA in your cancer cells, or DNA in your cancer cells, or DNA that's free in the blood from your cancer cells. And we are looking to see if there are certain genes that are mutated. And the idea is pretty simple. If you have a mutation, let's say in a purple gene, then we have a drug, a purple drug, that corresponds to that mutation that we can use to treat it incredibly effectively. In addition, if you have a mutation in a green gene, we have a green drug, orange gene, orange drug. And so the idea here behind next generation sequencing is we are looking for mutations in your cancer that we can take advantage of, a weakness in your cancer that we can use to attack it. Additionally, aside from next generation sequencing, we also do PD-L1, TMB testing, and MSI testing on your cancer. Now, the idea behind PD-L1 is that cancer cells oftentimes will make a protein called PD-L1, which will basically shut off your immune system cell so your immune system does not attack your cancer. And so what I want you to ask your physician is how many of the cancer cells in your body make PD-L1, this protein. And the reason I want you to know that is because the higher the level, typically the better response you'll have to immunotherapy. So immunotherapy is really simple. It's just treatment we give you to rev up your immune system, to recognize your cancer as foreign and attack it. So the higher PD-L1 that you have, the more likely you are to respond to immunotherapy. Similarly, if you have a high tumor mutation burden, you're oftentimes likely to respond to immunotherapy. So tumor mutation burden, it's exactly like it sounds. When you look at the cancer cell's DNA, how many mutations does it have in it? The higher the number of mutations, if you're TMB high, classically, you will have a much more likely chance of responding to immune therapy. The last thing I want you to know in this context is something called microcellular instability. So microcellular instability basically refers to how unstable is the DNA in the cancer cell. And what we know there is that the higher the level of DNA instability, the more likely you are to respond to immunotherapy. This is actually critically important. So all told, when we talk about molecular profiling, I want you to ask about next generation sequencing, PD-L1, TMB, and MSI. The last thing I want you to ask for, and this gets a little complicated, is something called homologous recombination deficiency. Now, homologous recombination deficiency is one of the ways cancer cells and normal cells repair DNA that might be mutated. And what we know.
Yeah, and then I found that last cleaning, and I remember you saying, like,
in their ability to basically do homologous recombination, then they're more likely to respond to PARP inhibitors, so poly-ADP ribose polymerase inhibitors, like olaparib, niraparib, veliparib, talazoparib, rucaparib. These are all drugs that are PARP inhibitors that we can use in patients who have homologous recombination deficiency in their cancer cells. So what I want you to do is I want you to write these 5 things down, stuff in green, okay? Particularly if you have an incurable tumor, NGS, TMB, MSI, PD-L1, HRD. You go to the doctor and you say, did you obtain this and what were the results? Now, I'm giving you some examples of specific genes and specific molecular abnormalities that we look for in cancer. You can see it depends on the stage, depends on the tumor type. I don't want you to have to memorize this. And in fact, I could have done this for every single cancer out there, including hematologic malignancies. This is something I do, I think, relatively well. I didn't want to focus on this. Someday I will do an entire talk on this for you. You can look at this slide if you want for reference. But the idea is the molecular abnormalities that characterize various tumors with various stages are different. They differ with respect to the cancer type. They differ with respect to stage in terms of what we look for. But this is what I want you to see. This is something most people don't show you. So this is a patient with stage 4 non-small cell lung adenocarcinoma with an EGFR exon 19 mutation. This patient, because of that mutation, that EGFR mutation, was given osimertinib. Now look at this patient. When they first presented, they had numerous lesions in the brain, numerous cancers in the brain. In 13 days, because of the mutation in EGFR, they got, after getting osimertinib, you can see in 13 days on almost osimertinib, there's no disease in the brain that's visible by MRI. But that's not just it. Take these 2 patients who both have stage 4 melanoma with a BRAF V600E mutation. So we look for a mutation in a gene called BRAF. It's a specific mutation, so it's BRAF V600E, which is present in about 40% of patients with stage 4 melanoma. And what we do when we see it is we give patients drugs, 2 drug combinations that basically target that mutation. Now, what you see on the left in patient 1, right here, you see a patient who presented to their physician with an unbelievable amount of disease. Look at this picture. You can see they had disease that infiltrated the entire liver. All that you're seeing here, this is all cancer. Cancer in the bones, cancer in the liver, cancer up and down the spine. Because they had that BRAF V600E mutation, they were eligible for a drug called vemurafenib. This was about 10 years ago. This patient got vemurafenib. 2 weeks later, there's no disease that you can see on the PET scan. This is the heart. It's supposed to look like that. This is the kidneys and the bladder. It's all supposed to look like that. There is no visible cancer left on the PET scan in 2 weeks on vemurafenib because they have this mutation. Now, look at this patient. This patient has disease up and down the spine in numerous bones throughout the skeleton. In 2 weeks with vemurafenib, because of that mutation, you can see that the disease has almost entirely dissipated. So this is why molecular profiling is so incredibly important and why you need to fixate on it if you have a tumor that is theoretically incurable. I want to say something here. There's a lot of patients throughout the world who present like this. And when they present like this, they oftentimes do so in the hospital because this oftentimes will cause symptoms. And so they will see a doctor who's not a cancer doctor, some internal medicine doctor who's serving as a hospitalist or somebody else. And that person will say, oh my God, you have a tremendous amount of disease, you're gonna die, you should go hospice, there's nothing we can do. Well, if they did that with this patient, they would have cost them at least a year of good quality life because this drug is going to likely work for a year looking at this response. And so that physician would have cost them a year out of their ignorance. And so I want people to understand that the only time you really learn about cancer as a doctor is when you do fellowship training. You don't really learn cancer as a medical school student. You don't really learn cancer as a resident. You really only learn cancer in your formal fellowship training. So people talking to you about cancer who are not oncologists most likely know nothing about cancer. So if you're talking to a hospitalist or talking to some other doctor and they're diagnosing the cancer, the very first thing I want you to say is, I want to see an oncologist. And I want you to see an oncologist every single time, because there might be something we can do that they have no idea about. They have zero clue about. So the very minute you're diagnosed with cancer, the next thing you say is, I want to see a cancer doctor. Look at this patient. This was just published in the New England Journal of Medicine in June. This is a patient, again, stage 4 melanoma with the BRAF V600E mutation. This patient got combination therapy, which is what we do nowadays. We used to use vemurafenib alone when it first came out in 2010, 2011. But this patient got combination therapy. This is what the tumor looked like when it started. Look at this 2 weeks later. Look at this 12 weeks later. So you can tell with me just showing you pictures. You don't have to even listen. Just look at the pictures. Just from the pictures alone, how important molecular profiling is, how it can completely revolutionize somebody's treatment course. Look at this picture. This is a patient with BRCA2 mutated triple negative breast cancer. I told you, the toughest type of breast cancer. So this patient had a mutation in BRCA2, which allowed us to use a PARP inhibitor, which is olaparib is one of them. You can see here that this patient initially had cancer in the right breast, in the right lung, and in the left lung. The image is reversed. And so with olaparib, which is a safe drug, very well tolerated, you can see the breast tumor got way better. The lung cancer on the right is gone. The lung cancer on the left is gone. Similarly, look at this 12-year-old boy with a spindle cell neoplasm. This child has an NTRK1 fusion, a different molecular abnormality. I don't care if you guys remember the abnormality, it doesn't matter. Don't even think about the abnormality type. Just see the forest, don't worry about the trees. This patient had a massive tumor involving the pelvis that you really couldn't resect. There's no way you can take this out and get negative margins and get all of it. So they took advantage of the fact that he had this fusion. They gave him a drug called larotrectinib. Shortly thereafter, the tumor shrunk, as you can see here. They removed it surgically. 9 months later, he's got no evidence of disease. So I need you to ask your physician, if you have a theoretically incurable cancer, about the molecular profile. Now, we talked about some of the actionable mutations. You just saw some of the mutations in the cancer allowing you to go to work with drugs that target those mutations. But I want to focus a little bit on immunotherapy now. So there's a lot of immunotherapies, you've probably seen commercials for them, right? So there's Keytruda and Opdivo and Tecentriq and Imfinzi and dostarlimab and cemiplimab and avelumab. There's 7 that are FDA approved right now, and there's a bunch in trial. There's a ton, toripalimab, sintilimab, segimilumab. There's a lot in trial that are coming out, or going to come out at some point. And the idea behind these immune therapies, right, is they rev up your immune system to attack your cancer. Now, we have fairly crude ways of trying to determine if we think immune therapy will work in you. And I already told you about them. There's PD-L1, MSI, and TMB. If any of those are high, I want you to immediately ask your physician if they're going to use immune therapy in your case. Now, I want to talk about one more thing. I didn't really talk about it earlier. There is something called mismatch repair, right? So mismatch repair is a process that the body employs to correct defects in DNA replication. So in our body, we have stem cells. They have to replenish the cells we need, right? So typically you have a stem cell that divides and forms 2 daughter cells. Now, what the stem cell has to do, it has to replicate the DNA to give an exact copy to both daughter cells. Well, that process of DNA replication is not perfect. There's some infidelity in that process. So we have numerous proteins that are involved in repairing any genetic deficits that occur during that process. And one of the ways we kind of fix those issues is with something called mismatch repair. Now, what we know is if cancers have mutations in proteins involved in mismatch repair, they can respond immensely to immunotherapy. So look at this. This is the New York Times article published in June. And I think many people saw this. Many of my patients rightfully asked me about it. What they did at Sloan Kettering is he took 18 patients who had a deficit in mismatch repair, 18 patients with rectal cancer, stage 2-3 rectal cancer, with a deficit in mismatch repair. So they were MMR deficient. That's roughly about 3 to 5% of all colorectal cancer patients, so rectal or colon patients. So they had 18 patients, 18 stage 2 and 3 rectal cancer patients with this defect, MMR deficiency. Now, typically with rectal cancer patients, they're stage 2, 3. We do chemotherapy with radiation, then we do surgery, and then we do more chemo, or we do chemo, then chemotherapy with radiation, and then we do surgery. But what they did in this trial is they said, look, let's see if we can help these patients without doing any of that, right? So they had these 18 patients that were MMR deficient, suggesting they would respond to immune therapy. They gave them dostarlimab immune therapy. All 18 of them had their cancer disappear, right? None of those people required surgery or chemotherapy or radiation. So the book is still out. Hopefully those people are cured, but that was a very promising result. Now, this trial was sensationalized a lot. It was sensationalized for a lot of reasons. I was extremely happy for these patients, but truth be told, I would expect this result to a very large extent. We already know in our stage 4 patients, we do it all the time. If patients have DNA instability, MSI high, oftentimes corresponding to MMR deficiency, they respond to immune therapy. So this result for me was not particularly surprising, but it was still awesome. Look at this patient. This is actually a striking result. This patient had a high tumor mutation burden. There were 76 mutations per megabase in the cancer cell. That's a lot. Anything above 10 is considered high. And so this patient had triple negative breast cancer. They're 55 years old, stage 4. You can see there were lymph nodes enlarged right around the aorta. There was a lymph node conglomerate right by the psoas muscle. And so when you look at this, you're concerned, right? Triple negative breast cancer typically does not respond to treatment very well. You're very nervous. Fortunately, because this patient was TMB high, they got an immunotherapy called nivolumab. And in 2 months, look, disease is gone. But what's more important and more amazing is at 4 years plus, the disease still hasn't come back. They're still in a complete remission. 4 years later, because they're TMB high, they got immune therapy that worked because they're TMB high. So when all is said and done, I want you to be your own hero. I just saw a statistic recently that was alarming. I saw that in stage 4 lung cancer, a significant number of people are not getting the appropriate molecular testing. That's scary to me. I'm not sure why that's happening. I'm not sure if that statistic's real or not. It was a study done. It was a pretty valid study, but done a little bit in the past. So I'm hoping that's not true. I haven't seen that in my colleagues, but sometimes you need to be your own hero. So just write these things down. Don't worry about the rest. Write down NGS, TMB, MSI, MMR, PD-L1, HRD. Take it to your physician and say, hey, is there a role for any of this testing? And if there is, did you test it and can I see my results? But you got to know your molecular profile. I believe in this so much that we actually started the Revolution Cancer International Molecular Tumor Board, July 16th. You can see it online. We actually are getting a lot of requests from patients throughout the world to review their cases. We will be doing that relatively soon. But I believe in it so much that we started this. Please go look at that if you want. Now, aside from everything we just talked about, histology, protein expression profile, molecular profile, you have to know how much cancer you actually have and where it's located. Look at these two patients. The patient on the left and the patient on the right both have stage 4 melanoma that's BRAF V600E mutated. Same exact profile. This is the same tumor type. So when you read the note, all it says is stage 4 melanoma. So you would think that these two patients are the same, but they are not. That's obvious, right? This patient on the left has disease in the liver, disease in the bones, like we showed before. This patient on the right has only a single spot in the right lung, which is why they have stage 4 disease. These two patients are absolutely not created equal. This patient is likely to do well and could potentially be cured. This is a patient of mine. We radiate this lesion, we put them on immune therapy, and I think this patient has a chance potentially of being cured. And so you have to appreciate that amount matters. And part of the reason the amount matters is because it lets us know what the room for error is, right? So if I see this patient here, I know for a fact I'm not going to get a second chance at this cancer. I'm going to get one shot. And if I'm wrong with that one shot, we're in trouble. So when it comes to melanoma, right, there's two options you have really with somebody with this mutation. You can use the drugs that target that BRAF mutation, or you can use immune therapy. Now, immune therapy takes a long time to work. And it also has a lower response rate. And so not for a second are you going to consider doing immune therapy alone in this patient. You're going to rapidly go to that BRAF inhibitor and the MEK inhibitor, the drug combination I talked about earlier, to try and extend their life with a good quality of life. And sure enough, that's what happens. Patient, I showed you the result. But amount matters. It tells you if you have room for error, and it affects your attack options. But location matters too. So if you have disease in the bones, we're going to typically give you a drug to keep your bone strong to prevent fracture. That's critically important. If you have disease in the brain, you have to understand that a lot of our treatments that we give through the IV or subcutaneously or in a pill will not work. A lot of them do not cross the blood-brain barrier. So we're oftentimes reliant on radiation. In fact, I hate it when my cancer patients have brain metastases because I oftentimes lose a lot of control. Now, fortunately, there are some drugs that actually cross the blood-brain barrier. It's important for your physician to know that, for you to recognize that, because if you have disease in the brain, it might make sense to use one of those drugs that gets to the brain and gets everywhere else. But the bottom line is you have to know where your tumor is located. It absolutely matters. It helps you know how to treat the disease and to understand your symptoms. Now, there's a scary thing I've seen in my career. And the scary thing is I've seen a lot of oncologists who never look at scans. Not only do they not show the patient the scans, they actually never look at it. And it always bothers me because I'm always thinking to myself, well, how do they know how to interpret someone's symptoms? If someone comes to me and says, I have pain at the L4 lumbar vertebra, they're not going to say that, she's going to say I have lower back pain, but it looks like it's at L4, L3, L5, something like that, right? Based on how their hips are located, you can kind of look and see where the disease is in terms of the vertebra, or where the pain is relative to the vertebra. So if I'm seeing that patient, the first thing I'm doing is looking at their scan to see if there's cancer there, right? Because I need to know, is this muscle? Is this degenerative disc disease? Or is this actually cancer? Well, how do you know if you never look at the scan? Similarly, if you're a patient, how do you know how to interpret your symptoms? I had a patient yesterday that we just diagnosed with stage 4 gallbladder cancer. She had a cholecystectomy, just a routine gallbladder removal. And the tumor invaded through the muscle layer of the gallbladder. And everyone thought it was localized, but I needed a PET scan because I was worried about it. And sure enough, we talked about this yesterday and saw it for the first time. The disease is everywhere, up and down the bones, everywhere. But this patient had had back pain for a while, and she thought she was crazy. She thought there was something wrong with her. When I showed her the pictures and you could see that there was disease in the spine, that was a relief to her. She understood that she wasn't crazy, and she now knew how to interpret that symptom. So when all is said and done, you have to know the amount of cancer you have in the location. And what I really want you doing is pinning your doctor down and saying, okay, I want to see my scans. You make them show you your scans. In part, that will make them look at the scans. So if there's somebody who doesn't look at scans, you want them looking at your scans. So it will force their hand. I want you to do that. In addition, it will make them sit down with you, spend time with you, and it will help you understand what's going to happen to you and what's happening to you in that moment. Another thing that you need to think about when you're trying to understand the team that's opposed to you, your opponent, you need to appreciate that no two cancers are the same in terms of their growth rates, their tumor biology. When I teach medical school students, I teach fellows. I actually did an 8-hour lecture series for the Roswell Park Fellows last year. One of the things I tried to implore them to think about is something we call tumor biology. And what I mean by that is, how is the tumor behaving? How is it acting? Get inside that cancer. Try and appreciate, is it aggressive or indolent? So what do I mean by that? When I think about cancer, I think about it as a continuum. There are some that are incredibly aggressive, some that are relatively indolent. And you can have aggressive stage 1 cancers and indolent stage 1 cancers, aggressive stage 2, aggressive stage 3, aggressive stage 4, and they can be indolent also. There are some stage 4 cancers, stage 4 lung cancers, that you would think would be disastrous, that just sit there and do nothing. You can literally just watch patients. It's actually kind of shocking. We don't understand why that happens. But it is your job as a patient and my job as a clinician to understand the biology of the cancer. How is it behaving? And remember, what happens is always more important than what you think should happen. You know, we like to prognosticate. We have all these different models to try and predict what your cancer is going to do. And oftentimes we're wrong. And we'll sit there and we'll say, why are we wrong? Well, it doesn't matter, right? I mean, it matters a little bit to try and optimize the model for the future, but it honestly doesn't matter. What matters is what you're seeing, what's actually happening in front of you. And so as a patient, I want you to fixate on that to a large extent, because appreciate one thing: cancer doesn't read textbooks. It doesn't care what I tell cancer it should happen. It doesn't care. And everything depends on this. Your treatment will depend on how fast things are growing, how well things are responding. Your prognosis will depend on how aggressive your stage 1 disease is, your stage 2 disease, stage 3, stage 4 disease is. And let me just talk about that a little bit more. Think about a patient with stage 1 breast cancer. Patient with stage 1 breast cancer, hormone receptor positive and HER2 negative. They come to my office after getting surgery. They have a great prognosis in general. Well, what am I doing in that particular point? Well, I'm trying to figure out, do I need to give them chemo? And how am I doing that? Well, I'm trying to figure out where they are on this continuum. Do they have a highly aggressive cancer with a high risk of coming back? Or do they have a low growth cancer, relatively indolent with a very low risk of coming back? And the way we do that, right, is we typically send something called Oncotype DX. We look at 21 genes in the cancer, and we can kind of put it into somewhere on this continuum. You can also do a mammoprint, but the bottom line is you're using these tests to put it somewhere on this continuum to determine, do I need to give chemo or not? So it matters a lot. Now, another thing I want to implore you to really think about here is I want you to think trends, not snapshots. Now, the natural question when you're diagnosed with stage 4 cancer is, how long do I have left to live? Every patient asks that question. They should. That's the question everyone should ask. I despise that question. I hate it. I think that patients should ask it, but I loathe having to answer it because I have no idea. I don't put an expiration date on people. My job is to try and keep you alive for a very long time with a good quality of life in general, unless you want to do otherwise. But that's my job. But the bottom line is, another reason I hate it is because more often than not, I'm going to be wrong. I'm not God. I have no idea. I don't have a crystal ball. But also, if you ask me in a vacuum based on one scan how you're going to do, I have no idea, right? Because I need to see the next picture. I need to know, how are you going to respond to the initial treatment? If you explode through the next treatment, well, that tells me we don't have a lot of time. If you do great on the first treatment and now there's no disease on the second scan, well, you have a lot longer to live. So I want you thinking trends, not snapshots. Think about time points. Okay, we started here. What did the next scan show? Did it look amazing or not? That's going to tell you a very big part of the story. In addition, in my humble opinion, one of the most important things in stage 4 cancers is if you can find a time to give a treatment break. Certain cancers, not breast cancer per se, not necessarily colon cancer, but certainly in pancreatic cancer, where you're giving a very tough regimen called FOLFIRINOX or gemcitabine Abraxane. You can't just keep pushing. It doesn't work. It's impossible to keep pushing a patient. So you're constantly looking for a treatment break because you're trying to extend their life for years, not months. So if you're thinking for years, you need to say, okay, I need to figure out a way to come off treatment if possible and to give them a treatment break. That's the holy grail. Well, when you try and decide, if I'm trying to decide if I want to give you a treatment break, and if you're trying to decide if you want a treatment break or not, you have to understand the risk and the benefit. And how are you going to know if you don't know the biology of your cancer? How does it behave? If you have a cancer that's exploding in real time on you, no way you're taking a treatment break. It's impossible. How are you going to do that? Unless you want to go hospice. I get that. But the bottom line is, not giving you a treatment break. Your cancer's exploding. Your cancer's just hanging out, and I know how it behaves, and I've learned it, where I've spent the last couple of years with you, and I know your cancer. Well, then I can figure out a way to give you a treatment break. And so this is critically important. Growth rate matters. And because the growth rate matters, I need you to ask to see your scans. Again, I want you to make sure you see your scans, not an imposition. Your doctor should be showing your scans. You're paying like $5,000 for a PET scan or even more. You should be able to look at your images. It's ridiculous. Now, there are so many things that the cancer is telling you while you treat a patient, and you're constantly trying to assimilate that information and say, okay, what have I learned about the cancer here and here and here? Because the more you know about the opponent, the better you'll do. Consider this patient of mine. This is a 85-year-old male with non-double hit diffuse large B-cell lymphoma, stage 4. Patient came to me in this particular situation, disease in the bone, disease right adjacent to the vertebra, disease in the liver. We gave them standard 3 cycles of R-CHOP. This works in 60 to 70% of people. It cures 60+% of people. Patient did well. Disease regressed pretty significantly because the liver is much improved. This big mass is improved. So we thought, okay, we're probably in the clear here. We're going to win, right? You think 3 more cycles, we're cured, we're done. Well, 3 cycles later, disease around the vertebra gets worse. This lymph node here gets worse, and now you know you're in trouble. You know that on that continuum, where you thought this patient was going to be very well behaved in terms of their cancer, you know you're in trouble now. You know you're dealing with a very different beast. And so now you say, okay, let's try something new. Let's show the cancer something it hasn't seen yet. So now you try 3 cycles of different drugs that target the cancer in different ways, right? So cancer's seen various treatment patterns. Now you say, okay, I'm going to show it a different mechanism of action, different method of attack, right? You don't practice insanity. You don't do the same thing over and over and expect the same different result. You want to do something different. So I showed this cancer 3 different mechanisms of action, well, 2. And sure enough, cancer exploded through it. And so now you know exactly what kind of cancer you're dealing with. So this patient got tafasitamab Revlimid, and we're moving on from there. But this cancer is very different than this one, another patient of mine. This patient has stage 4 mantle cell lymphoma, a notoriously aggressive cancer. So this patient, you can see, had a massive spleen. I mean, even in the world of people who do this for a living, This picture is striking. You will not see pictures like this very frequently. It is an incredible picture. We gave him treatment 3 cycles later, absolutely no disease aside from just minimal disease in the lymph node. I expect him to do extremely well. And so the idea becomes pretty simple. I need you to know your opponent. You need to understand the histology, protein expression profile, the molecular profile. You need to understand the amount of cancer and where it's located, and you need to understand the growth rate. But survival tip number 3, you have to educate yourself. Now, one thing that's happened in the last 10 to 15 years, as me being an oncologist, is that patients are becoming much more astute. They're really refined and they have a tremendous amount of knowledge about their cancer, and it's beautiful to watch. I love it. I absolutely advocate for patients to go online, to learn about their cancer, to press me, to push me, say, what about this? I read this, I read this, I read this. Good, that's what I want you doing. And the beauty is that 80 to 90% of people, cancer patients, search the internet when they're diagnosed. 80% go weekly, 47% go daily, and 91% of patients still go when they're confident with their knowledge. That's striking. But what I think is important is when you educate yourself and you advocate through education, you have to have the right sources. I could go through a million sources I think are reasonable. I'm just going to go through 2. You really only need to know 2. I want you to know nccn.org. So nccn.org, depicted here, is the National Comprehensive Cancer Network. It is a organization that's tremendous. And there's a lot of phenomenal physicians participating in this organization that really kind of help all of us understand how to treat patients like you. What I want you to do here is I want you to make an account not for patients, but for physicians or for staff. I want you to go here and to say, okay, medical staff. And I want you to say, okay, I'm gonna make an account, register, it's free. I want you to have the account that I do, because I want you to look at tremendous detail. So what you'll do is you basically make yourself an account, you'll go to guidelines, and you'll select the cancer that you're interested in. So let's say you select breast cancer. So what will happen next is you'll get this screen, you just click on guidelines. And sure enough, you'll get the breast cancer nccn.org guidelines. I want you to do this. You will not need to go anywhere else, honestly. You may supplement with other sites, but this site's going to tell you exactly what you need to know. So when you click on breast cancer, you will see that some key opinion leaders, people who are very good at breast cancer throughout the world, sit in a room and they talk about patients just like you. And they tell people like me how to treat patients just like you. So you can see here, someone with invasive breast cancer, they actually tell you exactly what the workup should be, what studies should be done. Then they tell you based on your staging, which you can see on the site, what should be done next. I want you to go to nccn.org. I want you to look at the cancer type you have. I want you to go through the algorithm and to know what should happen to you. Now, I want to be careful here. These are just guidelines, right? They're not dogmatic. And there are sometimes when we have to deviate from these guidelines. All I'll tell you there is if your physician is significantly deviating from these guidelines, you have to ask them why. There should be a good reason for it. Now, might be a tremendous reason for it. Your oncologist may be a genius, and that's awesome. But the bottom line is you need to know why. The other side I want to talk about, clinicaltrials.gov. For patients with incurable cancer, stage 4 breast, stage 4 liver, stage 4 colorectal in some circumstances, the first thing I want you doing, aside from asking about molecular profile and asking about scans, I want you to reflexively ask about clinical trials. I want it to be one of the first things out of your mouth. What trials are available to me? And I did an entire expose on clinical trials in some of the earlier sessions. You can go look at those. But the bottom line is clinical trials are where we test drugs, basically conduct experiments, testing drugs on your particular cancer, trying to provide hope where there was none. We're trying to extend your life with a good quality of life through experimental therapies that are not conventionally available to you. So what I want you to do is go to this site. Now, this is what the site looks like. I want you to click on the beta version up here. They actually did a great thing. They improved this site a lot. So this is the beta version. You'll just put in the cancer you're interested in, location, how long you're willing to, like how far you're willing to travel. Once you do that, you'll see all the trials here. Now, one beautiful thing I think a lot of my colleagues don't even know is they actually just put a download button here now. So you can actually download all these trials. It gives you an Excel form with all the trials that you can actually obtain from clinicaltrials.gov that you're interested in. I think it's awesome. So let's say you click on a trial. Now you can actually read about it. You can see if you're eligible. That's what I want you doing. But the bottom line is I want you to know nccn.org, and that's for everyone. I don't care what stage cancer you have. And I want you to go to clinicaltrials.gov, particularly if you have a cancer that's incurable, and go through that. Now, I believe so much in patient education, so much in clinical trials. I started 2 companies last year that will launch next year. One's in patient education, one's in clinical trials, doing revolutionary things. These platforms I think are unique, but I don't want to talk about them now. It's not something that really needs to be discussed. Survival tip number 4, play chess against cancer. When I see a patient, I am always thinking through this COMET acronym, and I want you to take this COMET acronym with you today. This is one of the critical things I want you taking from this talk, no matter what stage cancer you have. When I think through my therapeutic options for a patient with cancer, I think in terms of COMET. What are my conventional options, my chemotherapies, my biologic therapies, my targeted therapies? What are my systemic therapies? What are my operational options, my surgical options? What are my molecular-based options? We just talked about why that's important. What are my clinical trial options? And then everything else. And really, I'm talking about local regional therapies. So therapies we apply to a particular region of your body. I'm really talking about radiation, radioembolization, transarterial chemoembolization, things like that. I want you to take this acronym, and every time you see your doctor, I want you to say, okay, what are my COMET-based options? Whether you have stage 1 disease, stage 2 disease, stage 3, stage 4, what's the role for systemic therapy here? What's the role for surgery? What's the role for molecular-based options? What's the role for trials? What's the role for radiation? And I really want you to do this if you have stage 4 disease. So let's talk about stage 4 disease for a moment. When we see patients with stage 4 disease that's theoretically incurable, we typically use a first-line treatment until it stops working or patients can't handle it anymore. Then we go to second-line treatment and we use that until it stops working or patients can't handle it anymore. Then third line and fourth line and so on and so forth. I want you to play chess, not checkers, against cancer when thinking about this rubric. And the way to do that is to say, okay, what are my COMET-based options? What are my conventional options? What are my clinical trial options? What are my molecular-based options based on my profile? What are my local regional options? And when you do that, your doctor, who should be an oncology artist, should be able to take these options and make you a very nice treatment sequence based on putative efficacy, how we expect those drugs to work, to optimize what I call your treatment map through a practice that I call treatment cartography. The idea of making cancer patient treatment sequences, treatment maps that you can follow. So when you see your doctor, I want you to ask about these COMET-based options, and I want you to ask them what their treatment map will be for you. Why is it important? Well, a lot of oncologists might say this is too much. Don't need to do this. Well, wait a second. Let's say I want to put you on this clinical trial in third line. If I give you a drug that's involved in that trial in first or second line, now I've rendered you ineligible for that trial in third line. So I need to fully understand what's happening long-term. In addition, I need to always know what my contingency plan is. So I say this all the time, right? You don't need your cancer doctor when things are going good. That's not really my job. I can give you treatment that's easy to do. Many people can just pull it off NCCN. I just showed you how to do it. It's all cookbook. It's not hard to do. That's not the hard part of being a cancer doctor. And that's not the most important part. What you really need me to do is to be there when things are bad. When you've run 99% of the race and it's all gone well, you need me for that last 1% that's arduous, that's hard. You need me there. You need me to come up with contingency plans. You need me to know what the backup plan is. You need me thinking ahead. And if I'm not doing this, if I'm not thinking through this algorithm, I might be unprepared by the time you need a clinical trial. Now, I haven't gotten you ready. I haven't thought about it. I don't know exactly what to do. That's a very big problem. We already talked about the importance of this algorithm with clinical trials and molecular profiling, and I want you to reflexively ask about your COMET options, particularly with stage 4 incurable disease. Every single time you get a scan, I want you to say, okay, what are the COMET-based options? Is there a role for surgery here? Is there a role for molecular-based options? Is there a conventional therapy? Is there some sort of radiation I need? What are the trial options? Every time, because this is going to constantly change. We're constantly assimilating new information. Consider these patients here. This patient we showed earlier, stage 4 triple negative breast cancer, treated. You can see they're in a complete remission. This patient does not require a change in treatment. So the COMET-based algorithm is going to look very similar at this time as it did at the beginning. Consider this patient. This patient also stage 4 triple negative breast cancer. You can see we gave them treatment, responded very nicely in the lymph nodes and in the breast that I'm not showing here, but the liver got worse, 2 new spots. So this patient's COMET-based algorithm is going to change a little bit. Now I have to look for new trials because now we're 3 months later, did something else come out, right? Do I need to reassess the molecular profile? Do I need to send the tissue again to see if something changed in the mutations? Maybe I can target something now I couldn't target 3 months ago. So I'm always thinking about that. In addition, this patient's going to need a change in treatment. So the underlying paradigm here is if it ain't broke, like in this case, you don't fix it. But if it's progressing. You have to show the cancer something different. So you are constantly assimilating new information, and the choice of weapon matters, and you're adjusting on the fly. Survival tip number 5, you have to do the work. I think many patients get incredibly depressed about this diagnosis. That is completely understandable. Certainly, it's been shown that 40% of cancer patients have depression. But at the same time, in order to really optimize your ability to fight cancer, you cannot be an innocent bystander. You have to be an active participant. What's happening is a partnership between the patient and someone like me, the oncologist. I can't do the work for you. I can't exercise for you. I can't eat for you. I can't make sure you take your medications on time. And I can't make sure you tell me when you have a symptom and you're hypervigilant. You have to do the work. Now, in that context, I want you to know your treatment and your cancer. A friend of mine, ER doctor, told me recently that most cancer patients she sees in the ER don't know what type of cancer they have or their treatment when they're getting chemo. That is not acceptable. You have to know your cancer type, you have to know your treatment, and you should know what day and what cycle you are. Why is that important? Because if you go to the ER and they know what treatment you're on, and you can tell them where you are in the treatment, that allows them to address your issues more properly. So it's really important. You cannot be a passive bystander. You got to do the work. Survival tip number 6, it's a marathon, not a sprint. I think a lot of patients, when they're diagnosed with cancer, they think there's a beginning, a middle, and an end. And that would be nice. And for some people, that's kind of true. But then again, it's never true. And the reason for it harkens back to a Shakespeare quote, where he says, all the world's a stage and all the men and women merely players. The idea is, once you get a diagnosis of cancer, the stage upon which your life is played is forever altered. Anytime you have a symptom, even after you're theoretically cured, bone pain, headache, new little muscle thing, first thing you're thinking about is this my cancer coming back? So even when it looks like you are done running, and you're pretty much done running, you're still involved in a marathon. Now, with that in mind, knowing it's a marathon and not a sprint, you cannot do this alone. You really need to rely on your support system. Now, a lot of patients are fiercely independent. I think they're incredible, and I've seen it happen all the time, where patients don't want to impose on their family. Let me tell you something. Some of the worst pain I've seen caregivers have was when the patient didn't allow them to be there. People, they love you. They want to be there for you. They have to know that if things don't go well, that they were there. They can't live with the fact they weren't there for the rest of their life. They want to be there. Please don't do this alone. Be kind to yourself. There are going to be times when you look in the mirror, you don't recognize who you are. You're going to say, what the hell? You got to be kind to yourself. You have to understand you're going to have bad days, and you have to accept those. You have to understand that you're not going to be able to mow the lawn all the time and do all the stuff you used to do probably. That's okay. You have to forgive yourself and allow yourself to just basically let that happen. You need the declines to overcome the inclines. You know, some of the stage 4 patients we put them through chemo and chemo and chemo, and they are constantly running uphill. That's not possible. At some point, your physician has to figure out a way to get it downhill. Is there time I can take off of treatment? You've got to be thinking about the decline. So you got to ask your physician, is there a way to back off? I'm hurting here. Is there a way to give me time? It's incredibly important. To that same end, use your energy wisely. I always tell patients, when you have cancer, the ball of energy you used to have is probably going to be smaller, particularly if you have stage 4 cancer. You have a smaller ball of energy. I want you to use that energy optimally. I don't want you mowing the lawn if you have someone else that can do it and you don't like doing it. I don't want you cleaning the house if someone else can clean the house and you don't like cleaning the house. I want you to use that energy wisely. Use your support network. Now, I always tell patients that as a physician and as a caregiver, there are going to be times when you're running this marathon, all you need is us to hand you a glass of water, metaphorically speaking. Sometimes you'll just need us to cheer you on. Sometimes you'll need us to be in a pace car to pace behind you. And sometimes you'll literally need us to pick you up and take you across the finish line. It's your job to recognize what you need and to ask for it. Critically important that you realize it's a marathon, not a sprint, and you ask for help. Survival tip number 7, it's your boat. One of the first things I tell patients when I see them is that I'm the navigator, but they're the captain, right? It's my job to give them the options, to inform them of the courses that they can take, but they're going to tell us where we're going. Now, knowing that you're the captain, one of the things I want you to understand and to appreciate and to answer is the juice worth the squeeze? Now, a lot of people say, Basem, why are you saying juice and squeeze? Just say risk and benefit. No. The word risk doesn't remotely entail what you go through as a patient. There's a squeeze involved in chemotherapy. There's a squeeze involved in surgery. There's a squeeze involved in fighting cancer. It's not about risk, it's about the squeeze. And everything we do has some sort of squeeze. Your job is to quantify it. How much of a squeeze is this? On top of that, your job is to quantify the amount of juice you get for the squeeze. To do that, you truly have to understand your options. And to do that, you have to ask the right questions. And the number one question I would ask, if there's ever an impasse, ever a fork in the road, just ask your physician, what would you do if this was your loved one? What would you do if this was your mom, your dad, your brother, your sister, your wife, your husband, your child? What would you do? Understanding the squeeze component of this ratio is important. And I think a lot of people forget about some of this. One thing people forget about all the time is the time toxicity associated with what we do. The fact you have to keep coming back and coming back and coming back, that takes a lot of effort. Sometimes patients will drive an hour and a half, 2 hours to come see me. That's brutal. There's a time toxicity involved. You need to know that as a patient. Why? Because there are drugs that we can use to reduce the time toxicity. Let me give you an example. There are patients with stage 4 HER2 positive breast cancer that, or say stage 3, stage 2, whatever, that get Herceptin and Perjeta. Okay, now we can give both of those drugs sequentially in an IV over 30 to 60 minutes each, right? So you're there for an hour to 2 hours, right? We can do that. Or we can give you a drug called Phesgo, which has both drugs in the same formulation. We just give you in a subcutaneous shot over 5 to 10 minutes. Well, if you're a patient, why do you want to be there 1 to 2 hours when you can be there for 5 to 10 minutes? In addition, let's talk about immunotherapy for a moment. Drug like Keytruda, you can give every 6 weeks. Opdivo, you can give every 4 weeks. Durvalumab every 2, right? You can start thinking to yourself, well, what would I prefer here? Is the drug something where I can maybe space it out? So these are things you need to think about in terms of time toxicity, financial toxicity. There was recent legislation passed where the institutions need to tell you how much they're going to charge you. There's all sorts of surprises in cancer care. There should not be. Ask them, how much is it going to cost? And realize that cancer is the second leading cause of bankruptcy in this country. The second leading cause of bankruptcy. So please, please, please ask about the financial toxicity. Understand the physical cost. Make your doctor sit down, go through the side effects with you, understand what the physical cost is associated with the juice you're trying to extract. Mental health expense. Look, I don't think anyone gets out of cancer unscathed. It does something mentally. It may not make you overtly depressed. You may still be happy through it, but it's doing something. Please appreciate that. Please ask to see a psycho-oncologist if you want. They're there. Please appreciate that there's a mental health toxicity to what we do. Caregiver toxicity. People always forget this. They always forget about the caregivers. But caregivers go through a tremendous amount. The stuff I've seen in my life has been incredible. And I'm constantly fixated on the caregiver. And I'll talk about that in a moment. But there's a caregiver toxicity to us. Okay, so we talked about the squeeze. What about the juice? I want you to fully understand the juice. Understand the benefit. And when you do that, say, okay, what's the response rate? How many of these people actually respond to this treatment? What's the duration of response? When they respond, how long do they stay without having the cancer get worse? What's the survival benefit? How many of these patients actually live long-term? What's the cure rate? Understand the true benefit, and then you can make a full assessment based on the juice and the squeeze ratio. The other thing I want you to understand is, yes, you're the captain, so make sure you choose the right navigator. Now, I teach a lot of med students, fellows, residents, and they always ask me, Basem, how come your patients have the relationship they do with you, blah, 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 it doesn't matter. The bottom line is I always tell people when I teach that you really need to give patients the best of the heart and the best of the mind. Now, I think people thought when I advertised this or it was publicized that I would get on here and say, I'm a great doctor, I'm better than anyone else. That's not true, absolutely not true. My mentors were much, much better than me. And what made them incredible at Stanford and the Mayo Clinic, the NIH, National Cancer Institute, George Washington, what made them amazing wasn't just that they were brilliant, it's that they had gorgeous hearts and they infused their heart in every single interaction. That's what I want for you. I want you to find a physician and oncologist who gives you the best of the heart and the best of mind and has pristine hearts and pristine minds, because that's what you need. Because I'm telling you, as a cancer doctor, there are times when I am spent, when I am completely devoid of anything left to give. And in those moments, cancer does not care. It doesn't give a crap that I'm too tired. It's going to hurt you whether I'm tired or not. And in those moments, when my mind has nothing left to give, what compels me to find the answers is my heart. It's the reason I can't go to sleep at night until I know my patients are okay. It's the reason I think about them all the time. You want a physician who thinks like that. Now, how do you assess that? Well, One good way would be, do they know your caregivers? So I treat patients like family, right? So this is natural for me to want to get inside their life. Like I want to get in them. I want to know them, right? But let's talk about this for a second. When I'm talking to a patient and they tell me they like quilting every day, the minute they stop quilting every day, I know I'm in trouble. And it's because I know them. I understand what's happening. I can identify when there's a problem early because they told me they stopped quilting. Similarly, when I'm talking to caregivers, if I have a patient whose wife's a nurse, I know I'm protected. I know at home I don't have to rely on him to see the inches because she will. If I have someone who's in the room taking notes and loves the patient in the room, I know that I'm in a better situation, that they're not going to probably need me to watch them as closely because they'll at least report the symptoms properly. In contrast, if I have a patient who's no one else in the room, I know I'm in trouble. Now, I give every patient my cell phone number. They have my cell phone number and call me anytime. I implore that person to call me because I know they're going to need me. They're not going to see the inches properly necessarily. I need them to call me because they don't have the caregiver support. So not only is it important to get into a patient so you treat them like family, but it actually helps you care for them. Next issue when you're trying to choose the navigator, are they actually seeing you? Are you getting paid? Are you actually getting what you paid for, right? You go to these big name institutions, you see a physician assistant, or you see a nurse practitioner, you never see the physician ever. Is that really what you're paying for? Is that really top-notch care? That's critically important to understand. Now, the nurse practitioners and the physician assistants are amazing. I know some that are better than doctors, but it's really not what you're paying for when you go to a Mayo Clinic or a Stanford or an NIH or whatever. And I'll tell you, that doesn't actually, I'm sorry, NIH is not, or you're going to a Harvard. And I'll tell you, at Stanford, when I was with my mentors, they always saw the patient. Didn't matter that I was in there or the PA was in there, the NP was the attending, the person you came to see always saw the patient at every single visit. So it doesn't actually happen at Stanford. But if you go to other places, ask who you're actually seeing. Are you ever seeing the physician, or are you just seeing the advanced practice practitioner? Are they there when it's hard? So cancer does not care about an oncologist's schedule. And I'll tell you something, typically patients don't die in the room. They don't typically have issues in the clinic room. It typically happens at Saturday at 1 a.m. or Sunday at 2 a.m. because cancer doesn't care what day of the week it is or what time it is. And so what you want to know is your physician going to be there when it's hard? It's super easy to be when they're there when it's easy. You need me to be there when things are hard. When you've run 99% of the race and that was easy, that last 1%, if you don't finish it, when it's hard, it's like you didn't run the race. And you need me there in that 1%. So what you ask is you say, okay, what happens if I'm super sick? Who do I call? Are you going to be there in the hospital? Are you going to round on me? Are you going to actually take care of me when I'm at my sickest, when I'm getting symptoms for what you did to me? That is critically important. Does the physician teach? Do they show you your images? Do they spend time with you? Are they seeing you in the hospital and clinic? All of these are important. Choose physician over institution. Okay, there's tremendous institutions. Institutions are important, but they are not more important than your physician. You know, I always kind of laugh a little bit because people will talk about these big name institutions. They're giving the same exact drug that other community oncologists are giving. Literally same exact drug. It's exactly the same drug, not doing anything differently. And so remember, physician over institution. Institution matters though, because they will oftentimes have clinical trial options that are important. So you have a stage 4 cancer, you ask about clinical trial options and choose the place you go based on the clinical trials that are available to you and some other things I just discussed. This is an example of what I do in rooms. So I have hundreds, maybe thousands of these whiteboards actually, where I'm literally the first time meeting people, teaching them about their disease, literally going through everything, because I firmly believe that education manifests as improved survival. So I go through all of this with patients in profound detail, almost to the level of being pedantic. Survival tip number 8, know the down and distance. When you have patients in your office and you as a patient, it is very different when it's 1st and goal and you're about to score a touchdown than if it is 3rd and 10 and you need to pick up yardage. And the reason that matters, what we discussed earlier, if it is 4th and 31 and you have disease like this, that is no time to play games. That is no time to try and do experimental therapies, something that's undoubtedly not going to work when you've got something conventional you know is going to work. That is not time to play. It's 4th and 31. If it's 1st and 10, now all options are open. You can start to think about what to do because you have a lot more room for error. So it matters. Down and distance absolutely matters. It impacts treatment approach, and you are constantly reassessing this, right? It doesn't just stay 1st and 10. Nothing static in cancer care. Cancer's not waiting on you and saying, okay, 1st and 10, you win. That never happens, right? So you are constantly reassessing down and distance because you're going to determine your treatment options in part based on that. And I want you to, it helps answer a lot of questions specific to you, right? If you come to me and say, Basem, how long do you think I have left to live? Well, what's the down and distance? Are we 4th and 30 or are we 1st and 10? It impacts so many of the questions you're going to have. What treatment are you going to get? How long will I have to live? What symptoms am I going to feel? Well, what's the down and distance? Consider this example. This is a patient of mine with an ALK fusion positive, stage 4 lung cancer, stage 4 lung adenocarcinoma. So we initially treated him with a drug called brigatinib. When he first came in, you can see a disease in the lymph nodes in various locations, armpit, middle of the chest, neck. So we treated him with brigatinib. Things look great 2 months later. It's awesome. No disease here. You can't see that very well, but there's no disease left. He's in a complete remission. He does great until January 2022. So now he's had roughly 16 months of having no disease progression. Nothing has transpired. So basically when we started, we were 1st and 10 down 7-0. 2 months later, we're winning. We're up. We're tied 7-7. Sorry. So it's 1st and 10, 7-7. Now, all the way in January, no progression. We're winning. We're up 14-7. It's 1st and 10. Okay, good. Now there's a lymph node here. So we say, all right, there's just a small lymph node. I don't need to start chemo yet. Let me just switch gears and do a different ALK inhibitor, a different drug that targets that fusion. Okay, so good. We're 1st and 10 up 14-7. We can play around a little bit. Well, wait a sec. Now you've got a new pleural effusion. There's new malignant fluid here. You can see that there's disease in the pleura now. So now you lost yardage. Now it's 2nd and 20 and you're tied 14-14. The score is tied. You're no longer winning. So now you say, okay, I don't have time anymore. I have to go to chemotherapy. I actually use immunotherapy because there's PL1 95%. That's a little debatable. I admit that. But the bottom line is now June 2022, you just scored another touchdown. You're up 21-14. It's 1st and 10. He's in a complete remission. We're winning. Patient's winning. So survival tip number 9, be loud. Demand to see your physician, not just the PA and the nurse practitioner. Demand time and education from your physician. Demand to see your scans. Demand to see the COMET options. Walk in the door, COMET acronym in front of your face. Okay, what are my conventional options, my operational options, my molecular options, my trial options, and everything else? Ask for a second opinion if dissatisfied. Don't worry about the ego of your doctor. Who gives a crap? Ask for a second opinion, and when in doubt, call. Always call. Survival tip number 10, take cure seriously. There is a big difference between cure and treating someone to just keep them alive with a good quality of life. I want you to take cure seriously. Appreciate that when you look at a scan with a 1 centimeter spot, that thing is tiny. It's less than half an inch, right? 2.54 centimeters an inch, less than half an inch. That's 100 million cancer cells. So if you have 0.1 millimeter tumor, that's 1 million cancer cells. I'm never going to see it on a scan. That's why we give patients chemotherapy, radiation after we do surgery. We're trying to clean up the cells we can't see. And why? Because we put our foot all the way on the gas, because we're trying to make sure your cancer does not come back, because there's a world of difference between being cured and having a disease that's incurable. Ask about curative options at all times. Now, early stage disease, you should be readily cured, right? So go to nccn.org, look at the curative approach, and make sure that you're getting something that resembles that. But sometimes you'd be surprised who you can cure. Even as an oncologist like me, I get surprised. Look at this patient here. This patient has stage 4 colorectal cancer. They had had a number of resections, chemo, and the disease exploded afterwards. You can see all these spots in the liver. So what they did is they did a liver transplant. They actually transplanted his liver, and 3 years later, there's still no disease anywhere in his body. They potentially cured him with a liver transplant for stage 4 colon cancer. There are people doing this in the States. Mayo Clinic Jacksonville is doing liver transplants for patients with stage 4 colorectal cancer. That is not something that is intuitive. That is not something we typically think of. And I guarantee you, a lot of oncologists don't really think about this when thinking about stage 4 colon cancer patients. But remember to ask about cure and to push the envelope. Now, this gets a little bit crazy, right? I'm still not sure how I feel about this, because the amount of squeeze involved in a liver transplant for the juice that you're trying to extract may not make sense. And every patient's different. And so as an oncologist who treats everything, but in a lot of stage 4 colon cancer, I'm not sure how I feel about this yet. I haven't sent anyone for a liver transplant. But the bottom line is something you may think is incurable may not be. Look at this patient here. This patient is a patient of mine with Hodgkin lymphoma. It's 85-year-old COPD, Hodgkin lymphoma. This patient has an 80 to 90% chance of being cured of their disease, being cured. This is not a time to play games. It is not a time to talk about supplements that are unproven. It is not a time to go to Mexico and do something that's unproven. This is a patient with a highly curable disease. Go with conventional therapy that works. And so the idea here is he got 2 cycles of brentuximab and 2 cycles of AVD chemo, and he's doing extremely well. He still has a little bit of work to do, but he's doing awesome. So take cure seriously, control the variables. So I tell people this all the time, not just in cancer, in life, in business, control the variables. What do I mean by that? If you're trying to figure out why there's a problem, don't make 10 changes at once. You do 10 changes at once, you're not going to know what worked, what didn't work. Do one thing at a time, control the variables. In cancer care, I'm very careful to control the variables. I teach this. It's a refined approach. I only make one change if I can at a time. I take one thing away. I'll add one thing because I want to know exactly where we are. To this end, it's not the time for unknown and new supplements. They introduce a ton of variables. Imagine this. You're taking a supplement I don't know. I have no idea what that does in your body, right? Now I'm giving you chemo, and now your liver function enzymes go through the roof. Now there's a big problem with the liver. I don't know if it's the chemo I gave you or it's the supplements you took. That's a very big issue. It's going to put us behind the 8 ball because we will not understand what's happening to you. So this is not the time for new supplements. It's not the time for unproven therapies. Now listen, I'm a big believer. I don't know what I don't know. Some of these treatments may work. I'm not saying there's no validity to them, but it is not the time to play around. And please know that we are on your side. You know, a lot of people come to me, I want to go to Mexico. I want to go do this. I want to go do that. I'm on your side. Like if there was something I could give you that would cure your cancer and put me out of a job, I'd be the first person to give it to you. Like I would love for me not to have a job. I always tell people, you want me to be useless. I want to be useless. Like I would love to go find something else to do. I'm not sure what I would do, but I'd go find something else to do. So the bottom line is we're on your side, but there are a lot of people with bad intentions, a lot of people online trying to steal your money. And it makes me mad. You know, I'm so involved in my patients. I actually get viscerally angry when scans get worse. I get pissed at the cancer. I can't even explain it. I get mad. Similarly, I get mad when patients are being taken advantage of. I get infuriated. There are a lot of people online who will try and take advantage of you. In fact, 60 Minutes did a huge expose on how a significant number of supplements you buy at the store, Walgreens, CVS, Target, and Walmart, don't even have what they say is in it. So this is not a time to experiment. It's a time to try and take cure seriously. So ultimately, these are the 10 tips that I think you need to optimize your ability to fight cancer. The inches matter. Know your opponent. Educate yourself. Play chess against cancer. You have to do the work. It's a marathon, not a sprint. It's your boat. No down and distance. Be loud and take cure seriously. Final thoughts. Your journey is unlike any other. When you have met one person with cancer, you have met one person with cancer. Try and appreciate the personalized nature of your journey. Be the best patient you can be. I know that sounds cliche, sounds stupid, but I mean it. Know your treatment. Know your cancer type. Know what symptoms to look for. Tell me when there's an inch that's being compromised. You have to be the best patient you can be. Ask for help loudly. Don't worry about imposing on your cancer doctor. It's what they're being paid for. Don't worry about asking to see your scans. Be loud. You don't have an expiration date. Please remember, you don't have an expiration date. Go through the COMET algorithm. Play chess against cancer. Think outside the box. Think about clinical trials, molecular profiles. You don't have an expiration date. And hope springs eternal. You know, when I was 4 years old, first time I saw a cancer cell, there was very little anyone could do about cancer. Now, the field is exploding. Like every day, there's new drugs we hear about. It's awesome. And so as I teach my sons, this is my twin boys, about cancer, and I show them cancer cells under the microscope, what I try and impress on them is that this field is exploding, and there's so much we can do now that we couldn't before. So hope does really spring eternal. Lastly, I'll just say that we are doing this every week. This particular cancer patient education series, you can see us on revolutioncancer.com. This is not being monetized, not being sponsored. I'm not being paid. This is solely because I'm trying to give patients as much as I can before I die. I'm trying to touch as many people as I can in the shortest time frame possible. Thank you for coming. Appreciate it. I will take questions. Sorry, I will take questions. Hold on. Let me just unmute people. Does anyone have any questions? Any sort of, just raise your hand if you have a question. So hold on. Ollie has a question. Okay, Ollie, go for it.
Hello, Basem. Fabulous presentation. Wonderful information.
Thank
Two
you.
questions for you. One, could you just review again who are the best candidates for immunotherapy? And two, I know you've talked about this in the past. Just your thoughts about the GRAIL test and its effectiveness.
Yeah. So when we talk about immunotherapy, just understand we have very crude measures right now of trying to figure out who will respond to immune therapy and who won't. So we look at things like microcellular instability, PD-L1 status. We look at tumor mutation burden. And if you're high or in mismatch repair, if you're high in any of those or you're mismatch repair deficient, we think you'll respond to immune therapy. You're more likely to respond. But there are a lot of companies right now trying to develop immunotherapy prognostic assays to try and refine our ability to determine who will respond to immune therapy or not. So Oncocyte, OncoHost, Boston Gene, Natera, they all have tests that are trying to get better at predicting who will respond to immune therapy. With respect to the Gallery test being made by GRAIL, so for those that don't know, I wrote an article about this on biofilmreturn.com. That test professes to be able to look for 50 different cancers in a single blood sample. They want to essentially be an annual cancer screening test for patients at every single physical exam visit. And I think that that test still has a lot of validation that's required behind it. It looks somewhat promising, at least for later stage tumors. It doesn't do a great job for early stage disease. And so it's still a little bit problematic. They have a lot of work to do still before I think they become mainstream, but I will say that people are already prescribing it. So 2,400 physicians in this country are prescribing this test. Anybody in this room can get that test. It's potentially better than nothing. It's actually quite striking, but just realize that there are a lot of false negatives with this test. So just because it says you don't have cancer doesn't mean you don't have cancer. So I think there's a lot of work to do there, Ollie.
Thank you.
My pleasure. Any other questions from anyone else? Well, I can't tell you how much I appreciate everyone being here. Thank you so much for being here. It's extraordinary to have you here. We'll be back in a week. Please take care, everyone. Thank you so much. Have a good one.
Thank you.